Hey guys, welcome to chapter 33. This chapter is going to deal with orthopedic injuries and what we're going to do to take care of those injuries. As you can see, these are our national education standard competencies, and we just basically need to be able to recognize and treat the different types of orthopedic injuries. This chapter is fairly long, so it's going to take us a little while to get through it, but we'll make it. You're almost at the end of this section. So just remember, keep studying, keep your head in the books, and you'll do just fine. So there are some types of non-traumatic musculoskeletal disorders, and we'll talk about those a little closer to the end of the lesson. But just because somebody breaks their leg or arm does not mean that it's a serious trauma. There's some older people who can stand up and break both their legs, and that's from neuromuscular and osteopathic disorders. So the musculoskeletal injuries are easily identified because most of the time they hurt. If you're dealing with a fracture, you're going to have some swelling and deformity. Um, Not oftentimes fatal, but you can lose a substantial amount of blood from some fractures. And fractures, oftentimes, where we get concerned is the disability part or the morbidity part, not so much the mortality or the death part. It's that disability that we worry about. Orthopedic injuries do not take precedence over airway, breathing, and circulation. Okay, so don't splint your patient to death. The musculoskeletal system gives the body its shape and allows for movement. Um, your bones give the body its shape, and your bones protect things. It also allows your body to support itself. Your muscles allow those bones to move along with several other things. Um, your bones play a large role in developing blood cells. Your bone marrow, in particular, causes the beginning of the process of making red blood cells. That's why you can do an interosseous line or drill a needle into a bone and give medication and fluid because it is so vascular, because that's where our red blood cells come from. Muscles are composed of specialized cells that contract when stimulated to exert a force on part of the body. And what happens is your electrolytes causes your muscles to contract and relax. You have calcium, potassium, sodium. Those electrolytes move through the muscle cells and allow for electrical impulses that cause your muscles to contract. So for you to move your hand, your brain has to tell your hand to move, and then those muscles have to have electrolyte shifts in order to create an electrical impulse so you'll be able to move your hand. Skeletal muscle allows the body to maintain its posture and sit, stand, um, move. Muscle contraction requires energy, which is derived from metabolism. So in order for your muscles to work, you have to have ATP. Um, you need oxygen, you need glucose. If you don't have oxygen, um, then you'll get that acidosis or that anaerobic metabolism. All of you probably worked out at some point and became sore, and the reason you're sore is because of the buildup of lactic acid that you have in your muscles. And in a state of shock, your entire body does that. It gets full of lactic acid. Um, Muscle innervation. Skeletal muscles are innervated by somatic motor neurons. And all that means is skeletal muscle moves because of somatic motor neurons. And then muscles recruit those different electrolytes or signals to generate a more forceful contraction. And what that means is what recruitment is where you have more than one muscle or muscle fiber, a group of fibers working together to cause that muscle to contract. You're always stronger when more muscles work together. And then, everything in your body has to have a blood supply. So your muscles are supplied with arteries, veins, capillaries, nerves, just like every other part of your body is. And here's just some pictures of kind of the circulatory system and how that goes and what feeds what muscles. You should all be familiar with that at this point. So then you have the skeleton. You have the axial skeleton, which is your spinal cord. That's the central part of your body. It's your spinal cord, your rib cage, skull, and then you have your appendicular skeleton. And the easiest way to remember this is your extremities. So it's everything away from the trunk of your body. It's your pelvis, your legs, your arms. Those are part of your appendicular skeleton. The upper extremity extends from the shoulder to the fingertips, composed of your upper arm, elbow, and forearm. The radius and ulna make up the forearm, and if you want to keep those separate, just remember that your radial pulse is on your thumb side, so that's where your radius is, and your ulna is on your pinky side. The hand contains your wrist bones, hand bones, finger bones. These are also called phalanges or digits. Okay, those are your fingers. And then you have your metacarpals, that's the top part of your hand. Your carpals, that's your wrist. And here you can see where your radius and your ulna kind of articulate with your wrist. The pelvis supports the weight of your body and it protects the structures, like your reproductive organs, your bladder. Those are all down in your pelvis. So the pelvis is just a accumulation of bones. You have your iliac crest at the top. You have your ilium, which is that wing part. Your crest is the top part of the wing. Your inguinal ligament holds both sides of those. Acetabulum, that's where your hip joint is, and your ischium, that's back there at your tailbone. Okay, so those are the different parts of the pelvis. Big thing with the pelvis is if you fracture it, you can actually bleed to death. Each lower extremity consists of the bones of the thigh, leg, and foot. So that's your hip joint right there, your acetabulum. That's your femur. That's your thigh bone. It's one of the strongest bones in your body. Your kneecap is your patella, and then you have your fibula and tibia. And the way I remember those is you tell a little fib. So the little fibula is back here in the back, and the big tibia is right here in the front. And then you have your foot. Instead of calling it carpals like we do the wrist, we call your ankle tarsals. The top of your foot is metatarsals, and then your toes are phalanges or digits, just like your fingers. We talked about this just a second ago. Kind of got ahead of myself a little bit. But that's just another picture. And your heel bone is your calcaneus. A joint is where two bones come together. So sutures, that's the joints right here in your head. Okay? Those lines right there, those are the joints in your head. Those are called sutures. They do not move. Okay? Your shoulder joint, that's a ball and socket joint along with your hip joint. Okay? And those allow for circular motion. And then your hinge joint, that's your elbow and your knee. That allows your hand and your feet to swing like you're opening a door. The skeleton allows all kind of different movement. You have flexion, that's where you bring in. Extension, that's where you push your arms out. Abduction and adduction, that's the bending forwards and backwards of your arm. Rotation, that's circular motion. Circumduction, pronation, and supination, don't really get old over those, but you will need to know those first few. Bone classifications, bones are classified by their shape. Long bones, that's your arms, your legs. They're long, they're wide. They mainly function as support objects. Short bones are about as wide as they are flat. So you start looking at like your wrist, your ankles. Those are also known as irregular bones. Flat bones are thin, they're broad. You can kind of see those around your skull. And your sesamoid bones are round. You see those kind of where your tendons are, usually in your ankles and your wrist. A typical long bone has a diaphysis, that is also known as the shaft. Epiphyseus, that's the very top part right here. And the big thing about that is your epiphyseal plate or your growth plate is right up here at the top of your bone, and you don't want to fracture or do an IO in that. And inside the bone, you have your blood vessels and your bone marrow. Okay, remember bone marrow is where red blood cells are formed. Um, you have your spongy bone going down the shaft. You have your compact bone. Um, don't really get too concerned with the inside of the bone, but know the diaphysis and the epiphyseus and where they are and their importance. Tendons connect skeletal muscle to bone. Ligaments connect bone to bone. You will need to know the difference in those two. Okay? And cartilage is collagen is really thick, hard, spongy, almost like spongy bone. And the cartilage gives things shape and structure. And you also need cartilage to form new bone. So as you get older, your bones begin to deteriorate. You see here at 35, you have a few gaps, but most of the matrix, and this is called the bone matrix, this is the outside of the bone. And then as you get older, you start seeing these larger gaps. That's why older people are more prone to fractures. And this is actually what osteoporosis is. It's the breaking down of that webbing of the bone. Okay, it just makes it weaker, easier to break. Musculoskeletal injuries may result from blunt or penetrating trauma. A bullet from a gun will break a bone just as quick as a baseball bat will. Pathological fracture occurs from a medical condition. So pathological means disease process. So a pathological fracture has been caused by a disease process. We see this a lot with osteoporosis, and there's some other conditions that will cause your bones to easily break. So what's our mechanism of injury? Is it a direct blow? Is it some kind of indirect force? You can have pressure waves, those kind of things. We see twisting forces a lot of times, and that's where someone falls and they twist their wrist to try to catch themselves. And then you have high energy forces. This is your bullets. You're usually penetrating, but you can also have some blunt, high energy force trauma that will cause fractures. A direct blow fractures the bone at the point of impact. An impalement injury will cause soft tissue damage. We see this a lot of times with knives or stabbings, and sometimes that penetrating injury can also fracture the bone just due to the force. And an indirect injury occurs when force is applied to one region of the body that causes an injury in another region. Kind of an example of that is somebody jumps out of a second-story window, they land on their feet, but they end up with spinal cord fractures. So the energy is transferred from the heels into the spinal cord, and that's an example of an indirect injury. Person falling on outstretched hand may have one or more injuries as a result of forces transmitted proximally to the point of impact. So you can fracture your hands, your radius, your ulna, your elbow, dislocate your shoulder, clavicle fracture, and that's just because the energy is transferred from the hand all the way up the arm. Twisting forces are a common musculoskeletal injury. You think about football players and sprained ankles, sprained knees, and sometimes those twisting forces can be hard enough to cause a fracture. So, fracture is a break in a bone. Any break is a fracture, no matter how small or how bad. Open fractures mean the skin is open and the bone is exposed to the environment. Closed fractures mean that the skin is closed. A big thing with closed fractures is you have to keep in mind that we have to be mindful of compartment syndrome with those closed fractures. So angulation means the bone is crooked, is misaligned as a result of the injury, and an angle has formed between the fracture and the fragments. This is where you get funny L-shaped arms and legs from severe fracture. A non-displaced fracture is where the bone is cracked, but it's not completely broken into, and it will maintain where it's at. In a displaced fracture, the bone ends are separated. So non-displaced, the bone ends are together, not completely broke. A displaced fracture, the bone is completely broke, and those ends are misaligned. So this is a transverse fracture. It goes straight across the bone, almost in a straight line. Oblique fracture This is a slanted fracture across the bone. Spiral fracture, you see how it kind of looks like a candy cane? Kind of like that. That's a spiral fracture. Okay. Comminuted fracture is where you have bone fragments. A green stick fracture is a twisting fracture. You see this a lot in the wrist with old people. Incomplete fractures are where the bone is not completely broken into. Pathological, we talked about as being from a disease process. And epiphyseal is where you would have one up here in that epiphyseal plate. Signs and symptoms, we use the P's of paralysis for our bone fractures. We'll talk about those, I'm sure, in just a moment. But you may have deformity, and if the bone is crooked, it's more than likely broke. We see shortening and a lot of times rotation with hip fractures. Where the bone's broke, that extremity will be shorter than the other. And a way we tell a lot of times if someone's hip's broke is you see how this foot's rotated out. That's not a hip. I mean, that's an ankle fracture. But if this were intact and this foot were to be shorter than that foot, okay, we would suspect a hip fracture. Same concept with ankle fracture. Foot's rotated outwards, leg shorter than the other, and then you'll see swelling or bruising at the site. As a bone infiltrates the tissue, you'll see bruising and swelling. Fractures are often associated with bruising. So if you see a bruise like this, we would suspect a broke ankle. Bruise like this, we would suspect a broke foot. A fractured bone is almost invariably tender to palpation, and that means if it's broken, you go to grab it, it's going to hurt. Point tenderness is tenderness that is sharply localized at the place of the injury, so when you grab it, it hurts right there. Pain commonly occurs with fractures. If you ain't never broke a bone, it hurts. Patients are not going to want you to touch them. They're going to guard them. They're probably going to try to self-splint them, and they're really not going to want to move that extremity or that part of the body. You may feel crepitus, and that's a grating type sound where the bone ends rub together. It almost makes you want to grit your teeth when you feel it for the first time. And then false motion occurs at the point in the limb where there is no joint, which means when you grab a place, that part of the leg will move, and there's no joint there, so it's not supposed to move. And then lock joint is difficult and painful to move. A lot of times you'll get a joint that gets locked in place. And in an open fracture, exposed bone ends may be visible. So here you've got the tibia, the ankle joint popping out of the foot. Imagine the force it took to do that. Uh, in a dislocation, we see this with here they're showing a finger. We see shoulder and hip dislocations quite a bit. There's no fracture, but the joint has popped out. Okay, dislocated joint can go a reduction before you even start. Typically, we don't reduce a dislocated joint unless there's some kind of circulatory compromise. But as you're assessing your patient and palpating, sometimes those joints will pop right back into place. And subluxation or subluxation, however you want to say it, that is just an incomplete dislocation. That's just where the joint does not completely dislocate. You'll have deformity at that joint, swelling, pain, unable to move, self-splinting, tenderness to palpation, complete loss of normal joint function. That's called lock joint, where you can't move that joint. You may have numbness or compromised circulation. And a dislocation is considered an urgent injury due to its potential to cause circulation and nerve issues. We can reduce those if there's some circulation or nerve damage. So we want to make sure we assess the circulatory and nervous system status of those injuries. There are strains and there are sprains. Sprains deal with ligaments. And remember, ligaments connect bone to bone. So a sprain is where that connection point between two bones is. You'll have point tenderness, which means when you touch that area, it'll hurt. Swelling, bruising. Patient won't want to move the limb. They'll guard. They'll self-splint. and you may see some instability of that joint. It'll kind of be loose and wobbly. And then you have strains, and strains are injury to a muscle or a tendon. Okay, and you remember tendons connect muscle to bone, and what that is that's where you overstretch, and those muscle fibers, they just basically become torn or just stretched out too far, and swelling, bruising, pain. You'll see those signs and symptoms, and we call it pallor, which is paleness, paresthesia, which is numbness, pain, which hurts, and paralysis. And we treat these injuries using a acronym called RICE: rest, ice, compression, which is where you wrap it with an ACE wrap, and then elevation. And so we want to make sure that we're doing that, and we can also splint those extremities to prevent further damage. Your Achilles tendon, that is the tendon that allows your foot to move. It makes you walk. It's one of the most important tendons in your body. And what will happen is if you harm your Achilles tendon, you'll have foot drop, or your foot will point down and you're unable to pick it up. We talked about RICE. Long-term treatment may involve splinting, cast, surgery. So this is a long-term process. Usually takes a couple months, if not longer, for bones to heal. Amputation, that is where a limb is completely severed from the body. We see these in a lot of accidents, car wrecks and stuff, farming accidents. Part of the body, arm or leg, will get cut off. Hemorrhage, these patients may bleed pretty bad. A lot of times the vasoconstriction of the blood vessels will stop that bleeding, and you can control it with direct pressure. But don't forget, if there's a lot of bleeding and you can't stop it, go directly for your tourniquet. Attempts to splint and stabilize the patient condition are very important. Now, if your patient is a multi-system trauma patient, we're not going to do any splinting on scene. We don't want to splint our patient to death, and what that means is we take too long putting the splints on. But if it's an isolated fracture or sprain, you want to make sure you do your splints and your RICE and really take care of those. Patients are classified based on presence or absence of associated injuries. Isolated means there's no associated injuries. Multi-system means there's massive injuries everywhere. The golden hour is critical, not only for maintaining life, but for preserving limb. Because every moment that those bones are disconnected, that's just longer that you're lacking circulation, and that can cause you to lose a limb, or in some severe cases, the patient may even lose their life. So we talk about the assessment. We've talked about scene size up till we're all blue in the face. Make sure your scene's safe. Try to figure out your mechanism of injury. Do you need additional resources? And be alert for secondary injuries. What happened. Team that up with your mechanism. Focus on the patient's mental status, any major bleeding, airway, breathing, circulation, altered mental status or environmental issues. Do a rapid full body assessment on scene. And en route to the ED, you want to continuously reassess your interventions. Big thing is make sure when you splint somebody that you didn't wrap the splint too tight and cut off circulation, or that they're not swelling so much that you're cutting off circulation. Identify the injuries, prevent further harm. Evaluate your patient's level of consciousness. Check responsiveness using AVPU. Alert verbal, painful, or unresponsive. Give oxygen if they need it. What's your chief complaint? Mechanism of injury, life threats. We talked about that. Do your circulation, check for pulses. Make sure you're checking for pulses in the affected extremities. That's very important. And that should be reassessed every time you do your vital signs. Check the skin. Do you need to treat for shock? Do you need to lay them flat, high flow oxygen, keep them warm? Depending on what you're dealing with, depends on how in depth you're going to treat that patient. Make sure that you carefully handle the broke extremity or the amputated extremity. We don't want to cause any more harm. Get a history, find out what the chief complaint is, get your sample, your OPQRST, and check out that pain your patient's experiencing. Severe pain typically means that there's a fracture or some kind of musculoskeletal injury there. Your secondary assessment, this is where you really get down and find out what's going on. Look for any of those small injuries that you may have missed. More severe injuries increase when 2 or more bones have been broken, and that also causes an increase in blood loss. Do your full body scan. Identify the hidden and potential life threats. Do your DCAP BTLS, and we talked about what that means. Cover the 6 P's. We talked about those. Your paresthesia, paralysis, pain, uh, per, pulses, and pallor. Those are your 6 P's to a musculoskeletal trauma. Make sure you're evaluating your pulse, motor, and sensory, and always evaluate the joint above and below. And when you splint, always splint the joint above and below. That way you can restrict that motion. Do you see deformity, skin changes, swelling, muscle spasms? You see muscle spasms a lot with femur fractures. If you break the big bone in your leg, those muscles will contract and pull those bones on top of each other. Do you have a decreased range of motion? That can mean a fracture or joint issue. Is there color changes to the skin? Is your patient bleeding? Because remember, every red blood cell counts. And we're not just talking about external. Do we have internal bleeding? And we'll talk about some of those important bones here in just a few minutes that'll cause your patient to bleed severely. Palpate the bone. You're looking for your DCAP BTLS tick. Is it painful to palpation? Is the pelvis stable? You want to palpate the entire length of the bone so you're sure not to miss anything. And make sure you're palpating the neck and the spine and the shoulders. You just want to make sure you don't miss a fracture. And sometimes fractures can actually hide really bad other injuries. Check the neurovascular status. That means, can you wiggle your fingers? Do you have pulses? Do you have blood flow to that area? And you do that before and after splinting. Is the patient unresponsive? Evaluate the patient's limb for deformity, swelling, bruising, false motion, crepitus. All of those lead you to think there's some kind of musculoskeletal injury. Get your baseline vital signs and start your trend. You want to reassess that patient every 5 minutes to make sure that they're not bleeding out somewhere. Repeat your primary assessment. What are your interventions? What did I do? Is what I did working? Is the splint too tight? Am I losing pulses? Do I need to do something else? Secure critically injured patients to a lone backboard. A lone backboard is a full body splint. So if you put someone on a backboard correctly, you have covered splinting the entire body. And do you have problems with airway, breathing, circulation? If you do, make sure you're addressing those problems or reporting them or getting someone who can address those problems appropriately. Give complete descriptions of injuries and mechanism of injury, especially when you go into a trauma center. A lot of times they'll want to see photos of the scene, especially if it was a car wreck. Document if you had circulation or if you did not. And when an abnormality is identified, make sure you're documenting what you see, what you did, and what happened after you completed that part of your assessment. So, you always do your primary assessment, airway, breathing, circulation. Do your rapid trauma assessment, full body scan. Get your general impression as you walk up, BSI, PPE. Just basically follow your national registry sheet when you start doing your assessment. And if there's multiple trauma or if there's injuries to the trunk or even to the pelvis or femurs, be conscientious that can cause a lot of internal bleeding, especially those bone fragments lacerate an artery or one of the major vessels. Or if you're talking about the chest, you're dealing with the lungs, the heart, liver, spleen are right there at the bottom part of that ribcage. Musculoskeletal injuries can bleed, so if you have a lot of fractures, your patient may become hypovolemic. And we'll talk about the different blood loss from the different bones here in just a moment. Cold and heat application. What we do during the first 48 hours is we do cold, and then for the next 48 to 72 hours we use heat, and that'll kind of help keep the swelling down. And the cold will keep the swelling down, and the heat will increase blood flow, and that'll help that bone heal and get some of that edema and swelling out of that area. Splinting, they can be flexible or rigid. And when you splint, what you're trying to do is you're trying to keep that bone straight. You don't want it to move because that'll cause further injury. If you don't have splinting materials, you could use the patient. You can splint arms together. You can splint legs together. You can tie the arm close to the body. An injured leg can be bound to the uninjured leg. The arm can be bound to the chest wall or the trunk. We use traction splints for femur fracture, rigid splints, and formable splints Rigid splints are straight, they're boards, they won't bend. Formable splints you can kind of twist and bend to whatever your patient needs. Um, the best way to stabilize multiple fractures is to put the patient on a long spine board. It will splint the entire body. Remove clothing before you splint. You also want to visually assess that area. Make sure you're checking for pulse, motor, and sensory before and after splinting. If there's wounds or the patient's bleeding, you want to stop that first and address that bleeding. Um, don't move the patient before you splint them unless it's multi-trauma. Don't splint your patient to death. Pad all splints, and what that does is that keeps compartment syndrome or pressure and compression off that area of the body. Um, if a long bone fracture is severely angulated, if it doesn't have a pulse, what we do is we try to manipulate that back into line. Okay, and what we'll do is we'll hold on either side of the fracture and just kind of pull on it and see if that'll straighten back out. If that causes severe pain or you meet resistance, stop what you're doing, splint in place. Okay, and if you ever have any doubt, always splint. Be aware of the hazards associated with the improper application of splints. The first thing is you put the splint on too tight, or you have too much swelling under that splint, and you cut off blood flow. If you splint your patient to death, which means you spend too much time on scene putting splints on versus getting the patient to the ambulance and getting them to the hospital. If you splint and you decrease circulation, you have messed up. That's not your goal. Don't aggravate the injury. A lot of times when we splint, we have a tendency to want to move that injury around. Make sure you're not doing that. And injury to tissue, nerves, blood vessels, or muscles due to excessive movement will increase that injury. So we want to make sure we're not moving that extremity. Traction splint we use for a mid-shaft femur fracture. A couple pearls about a traction splint is if there's an injury to the pelvis or to the knee or to any joint, ankle, any part of that leg, you cannot put a traction splint on. It is for isolated mid-shaft femur fractures. And what happens is when your femur breaks, the muscles pull those bones on top of each other. That causes bleeding, additional swelling, more damage. So with the traction splint, we're actually pulling that bone back in line. And you want to be careful, not too much traction, just enough to get that leg back in line where it was, or you'll start tearing those muscles and you'll make the problem worse. Always check pulse, motor, sensory. And we don't force any bone back into place. If it will not naturally realign with gentle pressure, we're not going to force it. In the field, the goals of inline traction are to stabilize the fracture, stop excessive movement, to align the limb sufficiently, and to allow it to be placed into a splint. And avoid neurovascular compromise. You don't want to take a patient who had circulation and then you got involved and you cut circulation off. What traction splints do is you pull manual traction on the bottom of the foot, straighten that leg out, and then put your traction splint on. Do not use traction splints if they have injuries close to or involving the knee, pelvic injuries, any partial amputation, avulsion, any bone separation below or above that injury. Any kind of injury other than a mid-shaft femur fracture to that extremity is pretty much going to exclude the use of a traction splint. Hair traction splints kind of sit up in the groin, and what you do is you put a strap around the upper leg and then you just turn a knob until you get traction. Sager splints are easier. They're more lightweight, not as quite as hard, and they use kind of a spring action to pull that leg down. And then you have rigid splints, and this is where you get your board splints and things, and you can splint the leg that way. Problem with rigid splints is they're not going to hold traction. To apply a splint, it takes two people. You cannot apply a splint by yourself. Splint the limb in the position of deformity unless there's a compromise to circulation. When you encounter resistance or pain, stop what you're doing. Okay. Once you stop, apply gentle traction to the fracture and those bone ends may realign. Apply padded board splints on each side of the limb. You want to splint both sides of the limb, and you want to splint a joint above and a joint below. Pneumatic splints, we used to call these pneumatic anti-shock garments. mass trousers or PSAGs. They're really good for pelvic and lower extremity fractures. They'll splint those. Um, and then you have pneumatic splints for the arms, smaller extremities. And those are just where you put like almost looks like a float from a swimming pool around the arm. You blow it up, and the pressure from the air will splint that area. Um, Never inflate it before you put it on. All open wounds must be covered and bandaged with a dressing. In cold weather, sometimes that air pressure will decrease just because of the gas laws. And monitor the splint and let air out if circulation becomes compromised. We talked about the PASGs. You cannot use them, and this is important. We don't have them on the ambulances in Georgia, but it is still a national standard. If your patient's pregnant, chest trauma, heart failure, groin injuries, major head injuries, we do not use mass trousers. And you got to think those trousers, those pneumatic pants, are actually pushing um, blood and pressure from the lower extremities and pelvis into the abdomen, thorax, and head. So any major injuries to the abdomen, chest, or head, or mainly the chest and head, are going to preclude you from using those mass trousers. We use them for abdominal bleeding and pelvic fractures because that pressure will help control some of that bleeding. Formable splints, these are vacuum splints, pillow splints, SAM splints, swing and slough, pelvic binders, and we can form those to meet the need of the fracture. A vacuum splint, that's where you put it on and then you vacuum the air out, and that negative pressure causes the splint to hold the bone in place. Here's a picture of a pelvic binder, and that's a commercial one. And you slide it under the patient, and then you pull it tight to hold that pelvis together. And a buddy splinting, you fingers, toes, you just splint them together. So if you had a broke finger, you'd splint the broke finger with one that was straight. And you just typically just put a couple pieces of tape on there and splint them together. Very few, if any, injuries justify the use of excessive speed during transport. My company allows you 10 miles over the posted speed limit. Speed is more dangerous than it is helpful. A patient with a pulseless limb is given a higher priority. We want to restore that circulation as quickly as possible. If circulation in a distal limb is impaired, consult medical direction. They may want you to try to realign that. Musculoskeletal injuries lead to numerous complications. Likelihood of developing a complication is often related to the strength and force, the mechanism of injury. You want to prevent infection, cover any open fractures. Wash away any debris, and these patients may need pain management. As an advanced EMT, you can use nitrous oxide. If you're riding with a paramedic, they're probably going to go some kind of narcotic route for pain management. When blood vessels are damaged following any musculoskeletal injury, the patient may experience devascularization, and that just means blood flow stops. Displaced fracture fragments can lacerate nerves or blood vessels and can lead to paresthesia or paralysis. And we see neurovascular compromise most often with joint dislocations. And what happens is when the joint dislocates, it pinches those veins, arteries, and nerves against the bones in the upper body. Swelling causes compartment syndrome. And what happens is internally you have a lot of swelling, and that then shuts off the blood flow and causes your muscles to start to break down. You end up with rhabdomyolysis, which is the breaking down of muscles. Swelling is the main cause of compartment syndrome. We also see compartment syndrome like if someone gets trapped in a confined space area and there's a lot of pressure to that area of the body. You lose pulses from the swelling. You'll have electrolyte imbalances, tea-colored urine. Those kind of things will let you begin to think you're getting rhabdomyolysis or compartment syndrome. If a patient has a fracture below the elbow or knee, ask if they're in extreme pain, check for decreased sensation, see if they can stretch the muscles, and see if they have like a decreased strength in their hand. Muscles play a big role. They work together, so a muscle or bone injury in the upper arm will affect the lower arm. Elevate the extremity, try to keep it level with the heart. Below the heart, you'll get some swelling. If you elevate it to the heart level, it'll help the venous side return blood flow back to the heart. Use ice to control swelling, and that'll also help with pain. And loosen any restrictive clothing, because the more you swell, the tighter and tighter that clothing is going to get. Give them oxygen and normal saline or lactated ringers as needed for fluid maintenance or blood pressure. Um, Nitrous oxide for pain. And always reassess your pulse motor sensory. That'll let you know if what you did is working. This is a picture of a crush injury, and obviously they were crushed for a good long time. Rhabdomyolysis is tissue necrosis. We kind of talked about that with compartment syndrome, but all that tissue is dead. They're going to take that off, debride it. The patient may even lose their hand. Um, but that's called from something heavy slamming down on the hand, or it being entrapped under a heavy object for a long period of time. So now you have thrombolytic disease. We see this a lot, DVTs. We see it with fractures, but we also see it with the inability to get up and move, or sitting for a long time, and then there are some other risk factors. So you get disproportionate swelling of an extremity, discomfort or pain, warmth, swelling, redness is what you're going to see with your DVTs. Problem with the DVT is it comes unglued, and then it travels to the chest where it ends up in the lungs. That's where you have a pulmonary embolus. An embolus travels, a thrombus stays still. So a deep vein thrombus is a clot in the leg. A pulmonary embolus is where that clot has broken off and made its way to the lungs. You'll have a sudden shortness of breath, chest pain, tachycardia, increased respirations, right-sided heart failure, which means you may have some swelling in the extremities, shock, and pulmonary embolus will cause a cardiac arrest. If it's big enough, it will completely shut blood flow down to a lung, leaving you with only about 50% of the blood returning to the heart, and you'll die. Treatment for a fat embolus syndrome. This is the same concept as pulmonary embolus. A lot of times you have broken bones, you'll have pieces of fat that get into the blood. They'll stick together and go lodge in the lungs. Maintain the airway, give them plenty of oxygen, maintain blood pressure, and get them to a hospital. They need surgical or some for real pharmaceutical intervention. Injuries to the clavicle and scapula. This is your shoulder area. And patients with fractures to the clavicle will report pain in the shoulder. They'll hold the arm. Most of the time they'll self-splint until you get there, and then you can come in and put a sling and swath on. Young children will report pain all the way through their arm, and maybe they won't want to use that arm. They won't move it. Even when stimulated, they won't move that fractured extremity. Fractures of the scapula or the shoulder blade are fairly uncommon. Usually if you get hit in that area or something, the shoulder blade will fracture. But it takes quite a bit of force to fracture that shoulder blade. And being that its location is right here at the chest where your lungs are, assess for pneumothorax, check for your hemothoraxes, look for your rib fractures, look for those other injuries that could be associated with that shoulder blade fracture. The amicromoclavicular joint that's your shoulder. Okay, that's your ball and socket joint at your shoulder, and it can become dislocated, cause the joints to separate. Patient will report pain, usually deformed, no movement. Same concept as the other joint dislocations we talked about. How do you treat it? This is a sling and swath, and we'll go over this in lab. But you put a sling on the arm with your triangular bandage, and then you tie the arm to the body. So you see the sling here, and then the swath is right there. So sling it up, tie the swath around, and that will limit mobility of that joint. Remember, pulse motor sensory before and after splinting. To fully mobilize the shoulder region, a swath must bind the arm to the chest wall. You don't want the arm to swing and move. You want to completely bind that arm to the body and leave the fingers exposed. If you cannot check for a radial pulse, you can check for capillary refill in those fingers. And you want to make sure your patient can feel you touch them and make sure that they can move those fingers and really assess that pulse motor and sensory. It's just a picture of a shoulder location. And That's where the head or the end of the humerus, disconnects from the joints. Fairly common injury. Patient with dislocated shoulder will guard the other shoulder and try to protect it. Not going to want you to pull on it. The humeral head will protrude anteriorly, so you'll have some deformity up there. And the way you reduce it is just gentle downward pressure. You do not reduce unless there's a compromise to circulation. Stabilize the anterior shoulder, sling and swath. Tie it to the body good and tight. Put a pillow under the arm. That'll help with some of the pain and movement. Dislocation of the shoulder disrupts ligaments of the anterior shoulder. Dislocation recurs because these ligaments often fail to heal properly. So if you got loose ligaments, it's going to be really easy for that arm to pop out of place. Some patients are able to set their own shoulders if they have a condition of dislocated shoulders. Sometimes they'll pop them back in place. That means their ligaments are really loose, so the prospect of re-injury is pretty high. A shoulder dislocates posteriorly instead of anteriorly in about 1 of 20 cases. That means the shoulder pops out towards the back instead of the front. The arm will be locked in the abducted or the back position. It cannot be rotated. Posterior dislocations are fairly significant emergencies. Fractures to the upper arm. Proximal humerus results from falls, common in older adults, but these fractures can occur from direct or indirect trauma. Fractures of the mid part of the arm happen in kids, and that's usually from getting hit or hitting that part of the arm on something fairly hard. The radial nerve may be impaired, and just the force alone can cause injury to that nerve, so kind of keep that in mind. And a lot of times that nerve will get kind of hung up in that fracture site and basically cut off the feeling in the lower part of the arm. If the patient cannot hold their wrist up, wrist drop, that is a sign of radial nerve injury. If the fracture is angulated, longitudinal traction may be applied to correct the deformity. That's gentle pressure where you basically straighten it back out. Once the extremity is in the desired position, apply splint. That way it does not become more injured. Elbow, you see the nifty way they've got those splinted. Always splint above and below the place of the injury, and make sure your splint restricts, if not completely eliminates, movement of that extremity. Cold, pale hand or weak absent pulse and poor capillary refill indicate a reducing blood flow. If the limb is pulseless and significantly deformed, apply gentle traction and try to pull that thing back into place. Fractures of the forearm, the shaft of the radius and ulna are common in people of all age groups. Arms are broken quite often. Usually both bones break at the same time. You typically either have both or neither. Colles fracture, that's a fracture of the wrist. Kind of makes a bending appearance to the hand, almost like a fork. May cause some compromised circulation, so you may have to straighten that out. In that situation, always splint the extremity in the position of function. So the way the hand is in the bottom picture is how you would want to splint it. This is just a picture of a bone. You have your growth plates at the end, your elbow joint, your humerus at the top, radius on the thumb side, ulna on the pinky side, and then you have your hand. To stabilize fractures of the forearm or wrist, use a padded board splint, air vacuum, or pillow splint. If the shaft of the bone has been fractured, ensure to include the elbow joint in the splint. Splinting the elbow joint is not essential with fractures near the wrist. So if it's lower part, isolated to the wrist, you need to get the hand in the wrist. Any higher up, you're going to need to splint that elbow as well. Injuries to the wrist and hand. Need an x-ray. Got to have an x-ray to confirm a fracture. Isolated non-displaced fracture of the carpal bone is another type of fracture. Still going to need an x-ray for it. Hand injuries vary widely. Some can be serious, some not so serious. We always assume the worst and hope for the best. If a part is amputated, plastic bag, or wrap it in cloth, plastic bag, put it on ice, take it to the hospital. They may can reattach it. Pelvic fractures, this is a big deal. Lots of bleeding from your pelvic fractures. Okay, we see this a lot with blunt trauma. Your pelvis basically crush in on itself. We usually see it from the structures within the pelvis, the iliac crest, the ischium. Um, we talked about the blood loss and pelvic ring disruptions. Um, you see that in patients who have a stable injury and report pain or difficulty bearing weight. We see that a lot of times with falls. It's like a small fracture to the pelvic ring. There, you may see bruising, lacerations, bruising around the scrotum or the vagina, bruising in the flank or the suprapubic region or the groin area. They may pee blood. That's what hematuria is peeing blood. Or you may have blood from the penis or the vagina or the rectum in pelvic fractures. Lateral compression pelvic ring disruptions. Um, that's where you get hit on the side and it fractures the inside ring of the pelvis. And what will happen is the pelvis will actually become rotated inward. So you'll have some inward rotated deformity of the pelvis. This kind of gives you a picture of what it looks like. You can kind of see the rotation inward in that area of the X-ray. Anterior posterior compression pelvic ring disruptions. The force of impact compresses the pelvis from front to back. Causes the pubis symphysis, that's the bone on the front of your pelvis, um, and posterior supporting ligaments to tear apart. The pelvis then spreads apart, and what we call that an open book fracture, and that's just where your pelvis opens up, so you'll have a wider hip, lots of bleeding. Vertical shear fractures are from major force applied to the pelvis from above or below, and your shearing is just a up and down. Anterior component fracture of the rami or disruption of the symphysis pubis, and what we're talking about is you'll just have some deformity to the front of the pelvis or the back of the pelvis. That means you got a tailbone fracture or something in the back of your pelvis. Patient will have shortening, and they'll have massive hemorrhage into the pelvic compartment, so massive they could die. A saddle fracture is where a person lands in between their legs, and you basically fracture that bottom part of your pelvis. Open fracture is where there's a laceration of the skin in the pelvic region, the vagina, or the rectum. Those are considered open fractures. They're caused by high velocity injuries, lots of energy exchanged, and these patients will have massive hemorrhage. So any open fracture to the pelvis, your patient's going to have a lot of bleeding, and it's very difficult to control. So here's just some kind of pictures. The most reliable sign is tenderness on firm compression. So what we do is we push the pelvis in and down, okay? Once we do that, then we pull those wings out. At any sign of pain, the pelvis is fractured. Assume it's broke and don't touch it no more. Injuries to the bladder or the urethra, you'll have lower abdominal tenderness, blood in the urine, blood at the urethral opening. Do your primary survey, do your airway, breathing, circulation, immobilize the spine, do your 2 large bore IVs, get IV access. All pelvic fractures have the potential to result in massive hemorrhage. Reduce the amount of bleeding and decrease the degree of stability. Use your pelvic splints. Try to stabilize and reduce that bleeding. And talk to medical direction. Sometimes they'll tell you the best way to stabilize the pelvis. Use a binder, pillow splint, sheet splint. You could even use your pneumatic anti-shock garments to stabilize the pelvis. Once immobilized on a long spine board, patients should be rapidly transported to a trauma center. Do not log roll your pelvic fractures. Pick those patients straight up. Get plenty of help and pick them straight up off the ground and lay them straight down. Log rolling will cause the pelvis to fracture and compress down on itself and cause bleeding. Don't let the blood pressure get above 90 systolic. If it's falling, because you want to maintain that permissive hypotension. High blood pressures will increase the rate of bleeding. For almost all dislocations are posterior. Femoral head of the pelvis, we see this a lot of times with falls. That femur will dislocate from the acetabulum, and it usually does it posteriorly. Suspect hip dislocation in a patient who's been in an MVC and has a contusion or obvious fracture to the knee region. That force, that energy will pop that femur out of place. The femoral head rarely dislocates anteriorly. It's almost always posteriorly. and you'll typically see shortening and rotation in that extremity. Posterior dislocation of the hip is frequent. The sciatic nerve runs along that joint. The sciatic nerve will become inflamed. When the head of the femur is forced out of the hip socket, it may lead to partial or complete paralysis. Generally, only dorsiflexors are involved, so the problem is you're not going to be able to lift or bend your foot. Patients with posterior dislocations of the hip typically lie with the joint flexed. That relieves some of the pressure on the hip, and that extremity will be shortened and typically rotated outward. If you try to pull the toes to where they point up, you will cause severe pain. Severe hip pain, strong resistance when you try to move the joint. Lateral or aspects of the hip region will be tender or painful on palpation. Thin people, you can actually see the femoral head, and you may have sciatic nerve injury, which means the pain may radiate down one or typically I think it's the left leg, but it may rotate down one leg or the other. Do not attempt to reduce a dislocated hip. That typically needs surgery. Splint the dislocation. Pelvic binders work really good for those. Put them in a supine position, scoop stretcher. Do not log roll them. Okay. Fractures to the proximal femur, the top of the big leg bone. We call those hip fractures, but they typically do not involve the hip. The break goes through the very top of that femur or the neck of the femur, and sometimes can be fairly severe. Patients display a very characteristic deformity. Patients are unable to walk, and the hip region is usually tender to palpation. And then again, you have that shortening and that outward rotation of the affected extremity. Assess the pelvis for any soft tissue injury. Bandage all injuries appropriately. Check pulse, motor, and sensory before and after. After assessment, splint the entire lower extremity. You don't want them to have a lot of movement. Depending on the age of the patient and severity of the injury will determine, how delicately you splint the injury. The older they are, the more weak their bones are, so you want to be really careful. All patients with hip fractures may have significant blood loss, so go ahead and start your large bore IV to be prepared for that. Femoral shaft fractures. We see this a lot of times with the quadricep muscles begin to spasm and pull those bones on top of each other. Fractures are occasionally open where the bone is protruding out. Patient will have a lot of blood loss. Cover your wounds just like you would any other wound with a dry, sterile dressing. The foot or leg below the level of the fracture will have impaired circulation. Apply your gentle traction, realign the limb, and hope that circulation is restored. Look for your evidence of shock. Do full spinal immobilization if you need to, and establish IV access. You don't want to be behind the 8 ball. Be ready for that fluid resuscitation. Knee injuries, we see torn ligaments. You can also have a dislocated kneecap. We see this a lot of time with falls where people land on their feet, or in football or sports related, they'll twist their knee and turn around backwards. Assess the patient's knee. Do you have any significant findings? Injuries of the knee and ligaments, you'll see that on the internal, the medial side, and we see a lot of torn ligaments or sprained knees, those kind of things. Dislocation of the knee, the ligaments are probably going to be damaged or torn. And what happens is the knee has dislocated from the femur and the top of the tibia and fibia. Commonly, the ligaments in the front and back are damaged. Posterior dislocations are like if you get kicked in the knee, it'll dislocate posteriorly. Trauma to the front of the leg will push the knee backwards and cause the posterior dislocation. Medial dislocations result from a injury to the side of the leg. So posterior is an injury to the front, medial is a posterior side of the leg. If adequate distal pulses, leave it alone. Don't manipulate anything that has good pulses. If it has bad pulses, you can contact medical control. They may let you try to do a realignment. Fractures about the knee may produce significant deformity. It'll look like a dislocation, but there's actually a fracture. So if somebody has a dislocation, they need to be seen whether you can or cannot realign or reduce that fracture dislocation. Patient good distal pulses, leave it alone. Elevate the leg to the level of the heart. Use your cold packs for swelling. Frequently assess pulse motor sensory and transport them to a hospital. Dislocation of the kneecap. You can see that bulging swelling over there on the side. We see that with twisting quite a bit. Displacement of the patella produces a significant deformity in which the knee is held in a slightly flexed position. And that's just dislocation of the kneecap. Fracture of the shaft of the tibia or the fibula may occur at any place between the knees or the ankle joint. Both bones are typically fractured at the same time. We call these tib-fib fractures. Open fractures of the tibia are common. We see that a lot of times with falls, twisting motions. I saw it at a skating rink one time. Guy fell, bone started poking through the skin. Stabilize with a padded splint. Cover your wounds. Dry sterile dressing. Longitudinal traction. That means just pulling a little bit on it, try to get it to straighten up. And sometimes with the vascular injuries, once you realign the limb, the vascular injury takes care of itself. Ankles, sudden force, typically a twisting force, goes into the ankle. You'll see swelling, deformity, may have some decreased circulation because of the swelling. Stabilize the ankle. Use a SAM splint or some kind of commercial device if it's fractured. You may want to use an ACE wrap. That'll help it stabilize that ankle. Leave the toes exposed. That way you can assess for pulse motor sensory. Really keep an eye on that circulation. So stabilize ankle fractures using a commercially available splint. We talked about that. That's your SAM splints. Make sure you leave the toes exposed. That way you can assess distal pulse motor sensory. To reduce a fracture dislocation of the ankle, relax the calf muscle. Have the patient relax. Take the leg right there at that calf muscle, just below the knee, and kind of try to rotate that back into a normal position. Make sure you're monitoring pulse motor sensory and making sure you're not doing more harm than good. Foot injuries result in fracture of the tarsals, metatarsals, phalanges, or toes. Of the tarsal bones, the calcaneus is the most frequently fractured. Injury usually occurs when the patient falls or jumps from a height and lands directly on their heel. And what that energy compresses the calcaneus, producing immediate swelling, ecchymosis, almost like a crush injury. Frequently, the force of the injury is transmitted up the legs to the spine. We've talked about that, especially if it's a long fall. You'll see that compression. If you suspect that the foot is dislocated, check for pulse motor and sensory function. Look for lacerations, nerve damage. Treat those just like you would any other wound. Puncture wounds are quite common to the foot. Just know there could be internal bleeding on the other side of that puncture wound that you're not seeing on the outside. To splint the foot, apply a rigid padded board splint or an air splint, pillow splint. Keep that foot in line. Leave the toes exposed so you can assess pulse motor sensory. Check your neurovascular function. And all patients with lower extremities injuries should be transported in the supine position, and make sure you stabilize that injury real well. With amputations, partial amputations, ensure to immobilize the part with bulky compression dressings. All you're going to do is just splint that thing so it don't fall off. Hemorrhage from the amputations can be severe. Make sure you're doing your direct pressure and then going directly to your tourniquet. And make every attempt to preserve an amputated part. Wrap it in cloth, put it in plastic, and put that on ice. Do not warm an amputated part. Do not place an amputated part in water. Think about a fluid bolus, if they've had severe blood loss or they're hypotensive. And pay attention to the patient's emotional state. That increased catecholamine release or epinephrine release of fight or flight can cause the patient to go into shock by bleeding faster. And some people go into psychogenic shock. That's where you have vasodilation because of the sight of blood or pain or some kind of severe injury. General treatment is similar to that of fractures for your sprains and strains. We're going to do our RICE method, rest, ice, compression, elevation, splinting. Try not to put weight on it, and use pain management as soon as practical. The most common cause of post-traumatic stress with these injuries are the pain that's associated with them, so we want to make sure we're managing that.